research project conducted in Ministry of Health in Food and Nutrition Administration. Her research addresses the problem of obesity in the pediatric population in Kuwait. She is in charge of nutrition clinic for children with impaired area of metabolism, and she's currently a member of many committees and editorial director of the bulletin of our administration, Food and Nutrition Administration. Welcome, Dr. Nawal. And
evaluation and treatment of obesity. An epidemic of obesity affects children and adolescents across the developing and developed countries recently. And in most of the world, obesity is now the most common pediatric disease. I will not go through prevalence. I think it has been covered yesterday and today, so I'll skip it. But why does pediatric obesity matter? Actually, pediatric obesity is associated with a lot of complications. And one of the most important complications is that increase the risk of having adult obesity. As we can see in this slide, that as the body mass index of the child increases, the risk of being adult obese is increased. Actually, there is a lot of intervention, but how does it effective? Various systemic reviews provide an understanding the success of obesity-related interventions. And Cochrane review of child obesity prevention intervention, which is regarded as authoritative voice in systemic reviews in healthcare. He reviewed the Cochrane review reviewed 22 intervention studies, starting from 1990s to February 2005, and they reviewed 12 short-term study and 10 long-term. And the intervention included design which has act on diet and nutrition, exercise and physical activity, lifestyle, and social support. And it concluded that although many interventions were not effective in preventing weight gain, they were more often effective on improving lifestyle behavior. Mushini concluded that intervention were more effective in modifying knowledge than behavior. And also they could find that there is dose response in the effective intervention were longer in duration and had frequent booster session. While Thomas, 2004, noted that although some intervention found statistically significant improvement, most improvement were very modest. Ammerman, 2002, concluded that intervention appeared to be more successful with those who are at risk of obesity or obese and more than the general healthy population. In 2005, French found that overall school-based intervention that target food choices and eating behaviors have had positive results. And we can conclude from these studies that behavioral association with obesity it can be changes. And there is a lot of intervention programs has been held everywhere. One of them is the Australian one, Be Active, Eat Well. It was implemented by parent and local organization, include nutrition strategies, physical activity strategies, screen time strategies to promote healthy eating and physical activity. And it was run for several years. And the early result of promising, as it showed a significant result for most of the body composition measures in the intervention group. EBOT is another program. It is a French program launched in 2004. It is community-based intervention. Initiatives may include organizing games at school playtime, walk to school groups, and learning about vegetable and in the classroom. And they actually, the body mass index for children from 5 to 12 years have been calculated annually, and those who are overweight or obese recommended to see a doctor. And the results showed that half of the town showed statistically significant decrease in overweight and obesity combined between 2005 and 2007. Michelle Obama also has a program, Let's Move. It's creating a healthy start for children, empowering parents and caregivers, providing healthy food in school, improving access to healthy, affordable foods, and increasing physical activity. Actually, I will summarize obesity clinical guidelines from SIGN guidelines in UK 2010, Endocrine Society Clinical Practice Guidelines 2008, and the ICSI USA 2013. And for screening and diagnosis of obesity, what we can do, although there is a lot of techniques which can be used for screening and diagnosis of obesity, but most of them impractical for clinical use. Body mass index was adopted as the international standard clinical measures for obesity. And the body mass index score, actually the body mass index a bit different than the adult because it includes the growth. So that's why we have to keep in mind or consider age and sex. So because in Kuwait we are using the new WHO growth chart, I'll just go through how we can diagnose obesity using this chart. First, we have to use the 4 charts together: the length or height for age, weight for age, weight for length or height, and body mass index for age. And in order to diagnose obesity, the length for age, weight for age should be within a normal range, while weight for length and body mass index for age, if it is above 1D score, we can consider them as at possible risk. If it is above 2, we can consider them as overweight. If they are above 3, we can consider them as obese. Waist circumference measurement, one of the measurement, but usually it's not it can actually measure visceral adiposity, but it's not recommended in clinical practice. Skin fold thickness measurement is another measurement which can measure subcutaneous fat. Also, it is not recommended because it needs specific training and not visible for routine use in clinical practice. At the same time, it doesn't actually add anything or accuracy of identifying those children with highest body mass index associated with risk factor. Weight for height is another measurement which can also use in assessment of adiposity. We have to keep in mind and we have to remember that children at the age of 4 to 6 years have relative decrease in adiposity. And then they rebound it after that when they grow up. But those children who did not actually decrease their adiposity, usually they will be at risk of overweight and obesity. Now, how we can prevent child and adolescent obesity? First, parents are really very important. We have to include parents in the program. And as we can see in this picture, the father perceives his child as normal while he is obese. And if we didn't actually change his perception, we will not able to reduce his child weight. And there is some messages which should be directed for all parents, whether they have obese child or normal child. First, breastfeeding. Exclusive breastfeeding for 6 months is very important, and it has been discussed yesterday as an important factor to prevent obesity. Milk, American Academy of Pediatrics actually recommend that cow's milk should be used after the age of 1 year. Whole milk can be used up to the age of 2 years, and after that, we can use low-fat milk. But keep in mind, if you want to give low-fat milk, we have to give a supplement of fat-soluble vitamins. Child consumption of sugar-sweetened beverages is very important to be limited, and decreasing consumption of these beverages is one strategy to decrease total daily energy intake. The other thing, salt intake should be also limited to less than 1 gram up to the age of 1 month. Up to the age of 1 year. Then from 1 to 3 years, should not be given more than 2 grams per day, and a maximum of 3 grams per day for children 4 to 6 years. American Academy of Pediatrics recommends that no juice should be given to children, to infants under the age of 6 months, and 4 to 6 ounces of juice can be given to the children from 1 to 6 years, and no more than 8 to 12 ounces per day for those who are between 7 and 18 years. And instead of that, we can give actually the whole fruits and vegetables. And children can take 5 fruits or even more fruits and vegetables per day. Meal structure also very important. Daily breakfast is very important because it has been found that nutritional quality of the diet of both children and adults being better if they have breakfast. And the family should eat together at the same time as much as they can because family meal associated with higher quality diet. For children from 5 years and adult, eat well plate is suitable for them, even it is suitable for vegetarian. And child self-regulation, if the child allow actually to self-regulate their meal, it will be reduce the obesity. And encouragement of clean plate should be avoided. As we say in Kuwaiti, qamida, we always say qamida. This means that it's better to finish it instead of throw it. One study showed that when children aged 3 to 5 years old are allowed to serve themselves, they serve themselves less than if the plate being served to them. Eating out restaurant should be restricted, especially fast food restaurant, because it could find that frequency of eating out associated with body fatness in children and adults. Portion size should be also restricted, and we have to keep in mind that sometimes the portion size which has been written in the package usually less or even more than the recommended portion size. Physical activity is very important. It's recommended that children should get at least 60 minutes of moderate exercise. And for those who are suffering from severe obesity, we can advise them to program slowly and increase expenditure 10% per week. And those who already have injury before or predisposing condition, we can advise them to be evaluated by sports medicine physician and physical therapist. What about infant and toddler? American Academy of Pediatrics recommends that children younger than 2 years should not see TV while they can be supervised and while doing unstructured free play and activities. For preschool age children, 4 to 6 years, they can actually do 120 minutes of moderate to rigorous physical activity per day, and 60 minutes will be on structured activity and 60 minutes on unstructured free play. Sleep, very important. Evidence indicates that shorter sleep duration may be associated with increased risk of overweight among children 0 to 18. Not only that, in one study, it showed that for each 1 hour increase in sleep, the risk of obesity will reduce by 9%. And the following is the recommended sleep duration. For 0 to 5 years, at least 11 hours, 5 to 10 years, at least 10 hours, and 10 years and up, at least 9 hours. Sedentary behavior. The American Academy of Pediatrics recommends no TV for children, as we said, under the age of 2 years, limiting TV viewing or anything, a computer, iPad, iPhone, it should be less than hours for older children. Less than 2 hours. In a study of children aged 9 to 12 years, they could find that those who have TV in their bedroom were 1.3 times more likely to be obese than children without it. And the community is really very important to be involved in prevention of childhood obesity, and they can public policy effort. They can include a public policy effort to promote safe access to parks and roads. School have a big role, so there should be efforts to provide a healthy school meal, healthy food served in the canteen, decrease student access to competitive foods, and decrease the use of food as a reward. Schools are also encouraged to address these on their policies and in their curriculum. Now, how we can follow an obese child and how we can treat it. Obesity is a chronic condition, so it needs a chronic model. Integrated community resources, healthcare, patient self-management. And generally, the most effective weight management treatment for young people are both intensive and long-lasting, with intervention periods of at least 6 months. The aim of treatment should be, for most patients, is to maintain their weight, or we can say grow into their weight. But for those who are severely obese, we can advise them to reduce at least 0.5 kg per month. And should be dieting, actually, they should include diet, physical activity, behavioral approach to weight management strategy. Parents should be involved, especially for kids less than 12 years. And systematic evaluation of body measurement, diet, and physical activity should be performed at the baseline and then at a specific interval. In a cohort study reported that a reduction of more than 0.5 standard deviation body mass index was associated with a significant decrease in insulin resistance, and this was sustained in most of the obese children 4 to 17 years, 1 year after the end of the intervention. Now, how we can actually assess these children? Medical assessment and then behavioral assessment. Medical assessment, as we know, anthropometric measurement, blood pressure, family history, physical examination, and lab. Blood pressure should be, it's recommended actually to be checked annually for children less than 3 years. Lab tests should be done if the body mass index between more than 85th and 94th percentile, and if they have no risk factor, then no lab test is recommended for children between 2 to 8 years. If they have risk factor, then we can do fasting lipid profile, and even if they have, if the body mass index more than 95th percentile. For those between 9 and 18 and their body mass index more than 85th and 94th percentile and no risk factor, we have to do also a fasting lipid profile. If they have risk factor, we have to do fasting lipid profile, glucose, fasting glucose, AST, ALT, and it's recommended that lipid profile should be done every 2 years starting from 10 years, and the American Academy of Pediatrics recommend that we can do non-fasting lipido profile or HDL cholesterol for children. But if the result is abnormal, we can do a fasting one. And we have to, I will not go this, I will skip some slides. Okay, well, what about using drugs? Drugs, it can be used actually for those who are gone through a formal program, with intensive lifestyle modification, but failed. And for overweight children, drugs should not be used except if they have severe comorbidities. Orlistat is the only medication approved by FDA to be used in childhood obesity, and it is approved only for children more than 12 years, but no drug is approved for children less than 12 years. The other thing, metformin is another drug. Octreotide is also another drug. Bariatric surgery, the child, bariatric surgery can be actually used for obese children, especially if they attain tunnel 4 or 5 pubertal development, or has upon age more than 13 years for girls and more than 15 years in boy. Or those who have body mass index more than 40, or more than 35 kg per meter square and with severe comorbidities. And thank you.
Thank you, Dr. Nawar. I'm sorry we have to follow the time. Now we have 20 minutes for discussion. If there is anybody who would like to ask Professor James or Dr. Nawal or Dr. Iman or Dr. Schulenbergs. Any questions? If you'd like, well, I have a comment on yesterday, Professor James, your lecture was so harsh on Kuwaiti population, and today it is a fantastic lecture, and then complemented also by Dr. Nawal Gawd lecture. Solving obesity in Kuwait, whether adult or childhood, it's, as you both of you said, it's not a personal issue. It should be implemented by political rules and regulations, should be by the decision makers. It's not only the ministers, as you mentioned yesterday, it should be the kings, the princes, the ministers, and the presidents, because I was discussing this morning with my daughter that we are sending our children to private schools, and in spite of paying a lot of amount of money, they have no physical exercise, and the school canteen contains a huge amount of fat and sugar, and this school, one of the best schools in the Middle East or in the world. So here, it's not understood exactly what's good and what's bad for the population, especially in us in Kuwait.
Sorry?
Compliment your lecture and Dr. Nawal lecture that yes, we have to work very, very hard on.
Well, I'd just like to highlight, we've had fascinating lectures this morning, varying from the complications of childhood obesity and the psychological impact and agony, real agony of obese people trying to cope. In my world, I used to do clinics, and the top major psychiatric professor of England was just down the corridor, and he used to send me all his very disturbed patients. And I told him, don't send these patients to me. I'm no psychiatrist. You are the best psychiatrist. And he indicated that whatever I was doing was fine, because I did not blame the patient. And I went through a process of understanding their agony. Note the word agony. And in Kuwait, it seems to me that you're following the American and British idea that this is an individual's problem, and all the media and everything is concentrating. If you're fat, it's your fault, and therefore you have to change. And the evidence from France and other places is, let's take children. The EPOD study, I've been to the original EPOD towns, and I talked to the mayor. You have mayors here? In other words, the ruler of that town. And they had actually 6 officials doing nothing but spending all their time making sure that the schools changed their whole food, that the traffic was banned, cars could not take children to school, children had to walk to school, and they then talked to each other. And if they have to walk back towards their home, they automatically start playing with each other. So they become social, interactive children, not simply locked up in a particular world. And so I don't think Kuwait is going to have any hope of coping with the obesity problem until you understand that you built this city badly. You built it on American and British lines. That is a complete disaster because these cities were built for cars, not for people. And I've met somebody today who uses a bicycle, which is amazing. In London, we're trying to change the whole of the city so that the cycles come first, but in the Netherlands, bicycles get preference at traffic lights. They're on separate paths. Cars are a menace. You cannot take cars into Amsterdam, into the cities. In London, it now costs, I've forgotten, 10, 12, 11 pounds just to go in for 10 minutes into the city during the week between 7 in the morning and 6:30 at night. In other words, you penalize cars. Cars are a disaster. And until, you see, 95% of your food in Kuwait is imported. You have no regulations on food imports. You allow in the city fast food restaurants to be every 100 meters. Everything is organized to guarantee that you become obese. And so the problem is doctors spend all their time talking to individual patients. But when is the doctor's profession of Kuwait going to stand up and shout and say, we've got to change the system? That's what I'm looking forward to.
Thank you very much, Professor.
Dr. Iman Busiri, because you have mentioned that